should we just do, so we'll do all three and then take questions?
We'll do that. Yeah, that's the best.
Yeah, I think that's the best.
Because there are some sorts of, I mean, stuff
check
quite distinct, but there
check
are
what
some potentials for. I think should we get started then? Right, so it's a I must say that as I was saying to the panelists, I've been fortunate. I'm actually only attending. I'm attending the symposium in person only today for the first time, but I have actually been following using the very sort of excellent live streaming that's been going on. So it's nice to see people whose presentations I've actually been watching from across the country. Now, this particular panel engages with the issue of access to healthcare and public health infrastructure in the form of water and sanitation, and maybe helpful for us to think about the fact that at the end of conflict, there is increasingly attention paid to the fact that this is often an opportunity to intervene in health sector development to try and improve issues of equity in both access to health, but also in terms of health outcomes. And the three very interesting papers that will be presented today from the panel contribute to our understanding of this, how this process is progressing in both Sri Lanka and Nepal. And so from from Nepal, we have Suman Paudel, who's a research associate at the Nepal Center for Contemporary Research. And Suman's work sort of explores some of the ongoing challenges to improving access in the context of some largely positive reforms to health sector, state health sector provision in Nepal. And from Sri Lanka, we have two presentations from other sort of two ends of the spectrums of activity in this area. So on the one hand, we have Ramya Kumar talk about expanding private healthcare after the war in Sri Lanka, and Ramya is a graduate student at the Dalai Lama School of Public Health at the University of Toronto. And her work really looks at some of the shifts in the Sri Lankan state's approach to health sector development and the implications of these for access. And sort of in contrast to that, in terms of the scale of the study, Aftab Lal, who is a researcher with the Secure Livelihoods Research Consortium at SEPA, will be presenting a paper that draws on ethnographic data from fieldwork conduct on how caste mediates access to water and sanitation in a very particular neighborhood in northern Sri Lanka. So, without further ado, I'm going to get the panel started. What we will do is we will have each of the panelists present for 20 minutes, and we'll take questions at the end. And since we're quite a small group, I think we can be fairly flexible about how we do that, right? So I'm going to, just as afterwards, I'll indicate to you when it's 10 minutes gone, and then after that at 15, right?
For me as well?
For everyone, would you, is that fine with you? Okay, right, I'll do that. Okay, good. So first up is Ramya Kumar.
Good morning, everyone. In my paper, I'm just going to focus on one argument that I'm making, which is that the post-war health policy trajectory in Sri Lanka is actually weakening the public health system. And that I'm arguing that it's undermining the policy of free health, which is, that's what it's called over here, that has been in place for decades in Sri Lanka. So by health policy trajectory, I mean specifically the shift towards privatization of healthcare. And I use the term healthcare privatization in a broad sense, where I'm referring to any shifts that, to encompass any shifts any transfer of the responsibility of healthcare from the state to the people. So lots of people in Sri Lanka say it's not a privatized health system because we have public healthcare, but actually I'm looking at any shift that increases the responsibility of healthcare from the state to the people. For those who may not be familiar with the Sri Lankan health system, I just want to provide some background. So we have public and private systems running in parallel. Free health, that is healthcare without user fees, has been in place as state policy since the 1950s, and except for a few periods in between where there have been implementation of minimal user charges, it's been free for the most part. And the public system consists of a network of government-run clinics and hospitals that are spread across the country. These institutions are administered by the central and provincial ministries of health. Health services are meant to be accessible on a walk-in basis at any government hospital or clinic across the country. You can go to a hospital that you prefer, and there are supposed to be no user charges involved. Here I use the terms meant to and supposed to because that's not how it is actually working at the moment. The public health system is in Sri Lanka, so Sri Lanka is one of the few countries that actually has a system that can be considered under the umbrella term socialized medicine. All other systems that used to be like that have been reformed in recent years, but we still have a system that comes under that definition of socialized medicine, which means that health services are financed and provided by the government under one centralized system, and it's free at points of delivery and relies on tax-based financing and not health insurance or any other forms of what is known as risk protection. So this is all, this is in an ideal sense. This is not really what's happening because the system has weakened over the years. It's overstretched, overcrowded, long wait. There are long wait times, frequent shortage of drugs and other services, frequent strikes that disrupt services usually because the salary anomalies have not been resolved. These problems, I argue, are linked to the under-resourcing of the public system, and it's been gradually getting less state support over the years. But at the same time, the private sector has been expanding, and often these two, the connection is not made that expansion of the private health sector and under-resourcing of the public health sector is transforming our health system in a very significant way. And I think the reason why the public health system has continued to be in existence is that it's a very, I mean, it's a clear manifestation of public welfare, that the state is providing services. So I would say that the government and politicians have been reluctant to mess with this system, because if hospitals are closed down or clinics stop running, then people are going to be aware that the public welfare is being chipped away. So meanwhile, the private healthcare runs in parallel. There are independent institutions, and there's a very poor regulatory framework. So the strategy of privatization in Sri Lanka has been to gradually expand the private health sector while maintaining public provision of health services. How did this system become privatized? When did all this begin? So our health system was developed under, I mean, it started under health services were kind of free health came under British colonial rule, but rural expansion has occurred, and some have argued that it's because of a very strong left movement and other things like the malaria epidemic and even sort of colonial interventions like the Rockefeller funded Hookworm Initiative, which started this health unit system in Sri Lanka in rural areas. So that's where it all began. But so we had these two systems running in parallel, private and public, and then in 1977 there was a major shift with economic liberalization. Although again that shift was not full-blown privatization of public healthcare. The public sector was maintained while important steps were taken to expand private healthcare by allowing public health sector employees to work in the private sector. And actually this crazy channeling system that we have in place today emerged with this move. So other incentives that have been provided for the expansion of private healthcare include tax exemptions and allocation of state lands on non-commercial terms for private hospital construction. And this has happened, this happened in an important way between 2000 and 2004 when the UNP government was in power. And tax exemptions to the private health insurance industry, the health insurance for public sector employees to obtain private health services, and also, as is in place right now, 100% duty-free facility to import biomedical equipment. So basically the public is subsidizing the private sector right now. So these policies are reflected in what we have today. The private health sector accounts for over 50% of total health expenditure. Actually, it's almost 60. Now it's at 58%, and over 80% of this is funded out of pocket by households. So that's a lot of money that's been borne by households. So just to give you an indication of how much growth there has been in the private hospital industry, during the period between 1990 and 2011, the number of private hospitals in Sri Lanka increased from 66 to 125. So that's within 2 decades. And the private hospital beds doubled. The private share of capital formation increased from 7 to 19%. So that means that while the private health sector is being expanded in terms of, buildings and constructions, there hasn't been a accompanying expansion in the public sector, to equal that of the private sector. The share of private sector expenditure on inpatient admissions rose from 16 to 24% in that decade. So I want to highlight that here the private sector expenditure increased from 16 to 24%, but actually in terms of admissions, it's remained the same. So actually what's been happening is there's been an escalating cost of care, and it's not really being accompanied by equal increase in provision of health services, which is kind of indicative. It characterizes private health care where national costs of health care have increased with privatization. But the private sector has gained prominence in the provision of outpatient services, and the proportion of outpatient contacts is actually 50%. So it's something like 6% in inpatient, which means that the public is relying on government inpatient services, and more than around 50% for outpatient contacts, which includes channeling and GP practice. So these statistics are from Institute for Health Policy review of the private sector, conducted in 2012. Over 80% of expenditures on medicines and medical goods are financed by households. So in that category are included drugs, over 80% of drugs for conditions like diabetes, asthma, ischemic heart disease. They're all funded by household expenditure, more than 80%. But this is not to say, this is not to say that the volumes are equal. The government is actually purchasing drugs for less, so they provide a substantial volume of medicines, but in terms of expenditure, the private sector accounts for over 80%. And so just to give an example of biomedical equipment, the number of MRI scans was 6 in the private sector in 2011. Now, they were introduced in 1996. And they were introduced in the public sector much before that. And so in 2011, the number was 6 in the private sector and 4 MRI scanners in the entire public system. So now this brings me to another important point, which is that all this time we had the public sector kind of leading healthcare provision in Sri Lanka, but now the private sector is introducing all these new kinds of technologies. So I want to just show you as an example from 2014. So the Lanka hospitals today announced that it is now capable of performing keyhole surgeries, and it's the only hospital. Then the RCA Surgical Hospital, first with digital mammography. And Central Hospital opens bone marrow transplant unit. So there isn't a bone marrow transplant unit in the public sector right now. Oops, sorry. Yeah, so now the title of my paper is Expanding Private Healthcare After the War. And apart from wanting to make this paper more relevant to this conference, I also wanted to look at the government's post-war policy framework, which is the Mahinda Chintane Idiri Dakma, or Mahinda Chintane Vision for the Future, the post-war policy framework that's in place in Sri Lanka right now. So the message for the the health sector is pretty blatant. The plans within are all about increasing private sector involvement in the provision of health services. So the pressing health issues identified in Mahinda Chintane are an aging population, a growing burden of non-communicable diseases, undernutrition of women and children, and emerging communicable diseases. So ironically, these are the same issues that have been identified in the World Bank appraisal of the health system as well. So this narrow biomedical way of identifying health problems for priority allocation is it's deeply politicizing and has its roots in a colonial legacy of international health, which prioritizes vertical disease interventions rather than thinking of health systems as a whole. So Mahinda Chintane identifies the same problems as I said, as the World Bank report, as I said, and to address the identified deficits, it calls for a restructured Ministry of Health that will be more results-oriented and responsive to people's needs. So please pay attention to the language I'm using right now. So efficient management, state-of-the-art technology, and advanced information systems have become the most important thing now. And although the document emphasizes preserving the free health service repeatedly, the initiatives described are if undertaken, are likely to dismantle it. So these include developing a network of modern hospitals with state-of-the-art technologies, providing cutting-edge technology at an affordable price. Now, till this time, this affordable price was not even in the language of public health care. So now it's become, it's come into our policy. Improving facilities for research and clinical trials to encourage investment by international research firms, supporting medical tourism, improving health information systems, and expanding the medical insurance system. And all along, potential for public-private partnerships are emphasized. They create effective, efficient, and responsible service providers within a system that considers private and public health services on par with each other. Again, this is new to public health care in Sri Lanka. Under this framework, the government anticipates that all citizens of Sri Lanka will be covered by at least one health insurance program sponsored by different stakeholders, including private employers, government insurance schemes, and commercial insurances by 2020. So now this is like this visionary plan for our health sector, and more concrete plans within a time frame are in the National Health Development Plan 2013-17. So now I want to really, how much time?
You have 5 minutes.
Okay. So I want to really quickly go through some of the what's in this NHDP, the National Health Development Plan. Now, what's interesting is that I found some inconsistencies as well, which I want to just point out, and we can talk about them later. So can you just I'll just read out the highlighted, because I'm sorry, the print is, this is straight from the National NHDP. So now, interesting is that G is strengthening and recognizing laboratory services in government and private sectors. Then RST, so that's about promoting and regulating private health sector, improving public health, private partnerships, strengthening integrated approach. So that's all about getting more involvement with the private sector. And then there's promoting medical research, promoting medical tourism, and improving health financing, resource allocation. And this alternative financing options is like really hugely politically contentious. So then you go to like the different indicators under each. So those were the strategies, and then there are indicators to say, okay, this is what we're going to do. So now you see G, this is about bringing private sector in. But if you see, look at the indicators, or the, sorry, not, yeah, they were the initiatives, sorry, not indicators. So they want to, it's all about the public health system. There's nothing about private health care there. It's about improving the public health system. So, if you look at this, I've just highlighted Q and U because there's a Q, R, S, T, U. So here, R, S, T are about private health care, right? So they cut it out from here. So it's sadly omitted from this list of indicators in the summary indicators in the beginning of the document. And then they've forgotten to either, they forgot to omit it from the rest, or it was done sadly. I don't know what it is. But, but right at the end of the document, now this is about public-private partnerships, so I've highlighted the kind of interesting things, I mean, relevant to my topic. Outsource, how many? 2. Okay. So outsource identified services. So if you see cleaning, laundry, security, transport, now a lot of this is also undertaken by the people who are going on strike right now. So, I mean, if they just gave it out, I suppose that problem would be solved. And so establish, this is under promoting medical tourism. So identified sections developed in government hospitals, okay, will have medical tourism in there. And then this is, just look at the main strategy, this is what's under health financing. So there's, so fee for service for selected services by 2017, social insurance 2017, motivated local, okay. So again, the indicators are kind of vague and like they can probably get away with not doing anything about it. So, so the point I'm trying to make is that like why this sort of, why is there this contradiction here? How can we think about this? So just going into the World Bank Health Sector Development Report Project Appraisal. And so now the second health sector development project is currently under implementation. It's a US $5 billion project, out of which 200 million is only being given as a credit facility from the World Bank, and the rest is being, it's like conditional that the government provides the rest. So anyway, this second project is under implementation, and interestingly, there's just a vague reference to public, like having a dialogue with the private sector. There's nothing about the private sector. But then if you go to the first development report, the first health sector development report, which was under implementation between 2003 and 2010, you find that they had plans to pilot an alternative financing project, which for whatever reason didn't go through. So I have a little, like, less than a minute left. So, okay. So I just want to just say that what I feel in these inconsistencies is that, one, the government is reluctant at this point to move forward with this agenda. They're just getting rid of contentious things from reports and hiding them and doing all these things. I can't say whether it's because they don't want to. Maybe there are people in the Ministry of Health who, I mean, I don't really know anything to be able to speak to that, but clearly there's sort of this pressure coming from somewhere, and there's another pressure to resist coming from somewhere else, and this is but the lack of interest in this issue kind of makes me worried about what's going to happen. So the GMOA has not taken a stand on privatization. In fact, the union protested against the Private Medical Institutions Registration Act of 2006, which required annual renewal of private healthcare providers, you know, their registration. So they resisted that, but now they've changed their position after this medical doctor had this problem in the cosmetic surgical problem and lost her life due to like lack of care in this private facility. But generally they are not okay with, because the same people are actually working in both systems, so to protect their interests they would go against this kind of regulation. So my question, I guess, is why isn't the broader public talking about this right now, and are we okay with what's happening today? And perhaps it could be related to the fact that maybe even most of us sitting in this room right now, we don't really access services in the public system. The public system is really not on the radar of those who matter. Thank you.
Thank you very much, Ramya. And from the dismantling of free-to-access healthcare in Sri Lanka to the actual advent of free-to-access healthcare in Nepal, we're just going to jump over to Suman, invite Suman to come up and present some of the developments and the challenges in health sector reform in Nepal.
Thank you, Chair. I would like to thank SEPA for providing opportunity to share our findings. This paper is a part of SLRC research conducted in Nepal in 2013. In this paper, we try to show that how and what make people to have certain perceptions about the government relying on the health services provided by the health post in Rolpa district of Nepal in post-conflict scenario. Let's start from background. Before the insurgency, there was a heavy inequality in services based on caste, ethnicity, and regional base. And most of the especially poor and low caste people have low level of access to services because they are marginalized and they were not cared by the state. Especially when you talk about the regional mid and far western area where in low status of development. And during the insurgency, what happened? Maoists raised the issue of inequality and they gathered the mass behind their ideology. And they raised the inequality of caste, ethnicity, and started different campaign against the state, relying on the ethnic issue and caste issue. And another side, what they did, they attacked different government services to make the state fail. During the insurgency, there was a destruction of more than 1,000 health posts and health service centers. They kidnapped, killed, and abducted many health workers in rural area and obstructed health services. More the rural area, there was a less presence of state and there was a heavy presence of the Maoist. For example, in Thawang VDC of Rolpa district, there was no any immunization program for whole 10 years of insurgency. Let's come on after the what happens after the insurgency. After 2006, the government and Maoists did a comprehensive peace agreement, and they tried to prioritize the health issue by keeping it in the interim constitution. They stating every citizen should have the right to basic health services free of cost. And in 2007 and 2008, government increased the budget allocated by 24% in the health system. Again, the government brought the free drug program in 2008. 22 type of different medicines were provided from the sub-health post. 32 type of different medicines were provided by health post, and 42 different type of medicines were provided by district hospital free of cost to the people. In this paper, my research objective is to examine how service delivery influences people's perception on the government. Methodologically, this paper is qualitative, and 2 sites of Rolpa district were chosen, Liwang and Buragaon. 3 wards from each VDC were visited. Altogether, 52 different in-depth interviews were conducted to generate data. Among them, 26 were men, 26 were women, and Brahmin and Kshetri were 25, Dalit were 9, and Janjati were 18. I like to also express the limitations of the paper here. This paper does not reflect the view of service provider. Just it is based on the experience and expectations of the people. This is the study site. You can see the blue shaded there. That's the Rolpa district in the Nepal's map. And this is the map of the Rolpa district. This one is the Liwang, the headquarters of Rolpa district, and this one is the Buragaon. Comparatively, it has lots of service centers here, and comparatively it is very rural than this one. Let's come to the findings. The average distance of health post in Liwang was 45 minutes, and in Buragaon it is 55 minutes. But it depends upon the difficult terrain and landscapes. In health post, there is no doctor for the service. There is only the health assistant who is in charge of health post, and there are 3 more other health workers. in the health post, although there is a provision of free medicines, but most of the time the health posts do not have the usable medicines and expensive antibiotics. For example, in Rolpa, during the rainy season, the problem of diarrhea is very high, but not enough medicine. People could not get enough medicines for the diarrhea and vomiting. In Rolpa district, tuberculosis is high, but there is lack of diagnostic center in the health post. And because of that, people are really disappointed on the ability of free medicines, which were assured by the government, but not able to get that. And even the services, there is no any X-ray and lab facilities. But expressing a frustration, a youth of age 20 years of Liwang says, the health post is not enough. We cannot even get free medicines from here. I had to return bare hands. I had gone there because of fever, but health assistant checked me but suggested me to buy medicines and bring the report of blood test from private health clinic. Then what would be the meaning of free service and free medicines? That's the real case. When you go to the health post, you will health assistant just check your pulse rate and see your eyes and tongue, and that's all. And there is no any diagnostic center, so you need to go to the private clinic for the diagnosis, for X-ray and other kind of stuff. And when you come back to the with the report, and then the health post will provide the medicine. But even in that case, people are not getting the free medicines. This is the case of Rolpa. For that kind of problem, there is no any monitoring body from central government, even from the local government. People could not go anywhere for the complaint and other kind of stuffs. And people are not being benefited as it is supposed to be. And you know, the service from the health post is taken as a lock factor. A Dalit expressed his opinion that I first go to health post, it is 45 minutes of walk. If we are lucky, we can get free medicine and services there. If not, we have to go to private clinic. But I first go to health post. Although the first priority of Dalit people is to go to the health post to get the services. But you know, there is lack of health medicine and there is lack of health diagnostic center. So that depends upon the luck, they think. If we are lucky, then we can get service. If we are not lucky, then we need to go to private and spending the large amount of money. In that case, you know, the inaccessibility of required service and physical inaccessibility promoted the ill and traditional practices among the people also. Among 52 people, 12 people seek traditional way of treatment. 3 said because of distance, because their house are very far from the health post, so they seek the traditional way of treatment. But 9 people say that there is not enough service at the health post, that's why they go for the traditional way of treatment. And the majority of the people who seek for the traditional way of treatment are the Dalit people and marginalized and very poor people. Among 52 respondents, 30 participants say that there is no any kind of discrimination now, so the Dalit people can freely access to the health service. But still, people are not getting accessibility. For the reduced discrimination, people people just gave the Maoist campaign as a main source of reduction of the discrimination. They said that because of Maoist campaign and Maoist movement in their area, ethnic and caste movement, the discrimination has been really reduced. And they do not feel any kind of discrimination in the public services centers. During the insurgency, what happens? Maoists have started their revolution based on the Maoism. It should be based on the class inequality. But what happens? After some years, they realized that the class inequality would not work in Nepal. That's why they pick up the slogan of inequality between caste and ethnicity, which become very famous, and the Maoists strengthen their position in the Nepalese politics and as a strong rebellion. Even you know, in the Rolpa district, the discrimination has been such a reduced that in Kathmandu capital you can see a widow people wearing a white sari, and she is not allowed to wear red sari because red is a symbol of your living husband. But in Rolpa, lots of women were wearing the red sari. That's the kind of very good implication effect has been produced by the Maoist movement in Rolpa district of Nepal in such a rural area. You know, the political awareness and confidence has increased the accessibility of service among Dalit and poor and marginalized people, but inability perpetuates additional social suffering and discourages people from trying to access health services. Hence, establishing service center is not enough, but availability of needed services, accessibility in real mean. But there is not only the failure of health post in Rolpa, but there are some cases where the health posts are really good. But for example, we can say health post is very good for the vaccination and maternity health services. The health post launched several vaccinations like BCG, DPT, polio, and other kind of stuff to reduce the infant mortality rate and disability rate. In that case, Rolpa is really doing good. There has been increased the awareness on vaccination, and there has been increment in trend of child delivering in health post also. A Dalit woman of Budagaon say, that means he took her daughter-in-law 4-5 times health post for regular checkup and got 1,000 rupees as a transportation fee when she get the delivery at the health post. And she was saying everything was good about maternity, so I am happy. The transportation fee which is providing by the government is also promoting the child delivering in health post. Culturally, it has been tradition for women to have their babies at home, but now this has been being changed because of female health workers mobilized by health post. Because women feel very free to share their problem about pregnancy and other kind of their own personal health problem. That's why the mobilization of women health workers from health post has been really effective among the female service users. Female are most benefited and happier than men for services because most women visit health post. Women are very busy on their house stuffs and they do not have very much time to go to the urban area and town centers for checkup. But what happens when there is a health post nearby their house, they have little bit time to go to the health post for checkup and discuss about the health problem with women health workers. And there is also, because of allowance for transportation, the women are really getting benefited by delivering child in health post. And the strength of health post is female health workers, which is really being effective in Nepal. And what is the problem also there? As much as these women are visiting health posts, they are being aware about health problems and services, but these health posts are really unable to provide the desired and required services furthermore. And I also like to say that the government health study is not friendly to poor people. You know, the complex service centers, district hospitals, zonal hospitals are only urban centric, where the urban center, at the urban center, the people have very low level of health problems, but in rural area, people have very high level of health problems. Due to the different associated costs, the free services provided by health hospital do not remain free. You know, for a Rolpa people, they have to go to the district health hospital if they are referred to that. And what they need the transportation cost, they need the accommodation cost, and they need lots of different associated costs to go to the district health hospital and zonal hospitals. And that makes the free services of hospital and zonal hospital do not remain free. They have to bear large amount of money, which really makes them economically vulnerable also. And the crisis in primary health care has forced to visit expensive health centers in Kathmandu or India even sometime. Hence, I could say that establishing a center is not enough. need to be fulfilled required services. In that sense, the lots of people who are very poor are really not getting the services provided by government because of their poverty. Majority of people have very low level of trust and confidence in both level of government, central as well as local government. And I like to conclude that some reasons that make people feel frustration against the state service from health post are health services are inaccessible to those people living very isolated area, remote area, and very slow pace of decentralization process also. And there is very inadequate supply of equipments and drugs, and lack of skilled human resources, and weak supervision by central government. But in post-conflict scenario, some very positive implication of Maoist movement has been seen in the Rolpa district also. Maoist movement resulted reduction in discrimination and strengthened the confidence among Dalit, thereby increasing access to Dalits. But Dalit continue to experience exclusion because they are often unable to negotiate with the system because of their poverty. Given the social demographic of the field area, women are the largest user of the public health system, but they also have more expectation which is not assured by the state. Thank you.
Thank you very much also for bringing that presentation in under time. So from one context where we have, Vijay, I see what Vijay has done now in constructing these, because from one context where you have a militant movement that had a very strong caste discrimination policy to another that certainly was claimed to have. But we shift to northern Sri Lanka, where Aftab is going to talk about the survival, in a sense, of aspects of caste discrimination, which is a hugely under-discussed issue in the Sri Lankan context and in the literature, and how that impacts on access to water and sanitation. Right.
Okay, good morning everyone. Thank you for being here.
Just, I think if you don't mind
talking into this?
Just because I think for purposes of the streaming and later turning it into YouTube videos.
I see. Okay.
Which I'm sure you're thrilled about.
Okay.
You just need to.
Like that? Yeah? Is that okay? Right. So I arrived in Jaffna sometime in mid-September last year. This was in the heat of the campaigning for the much awaited provincial council elections. I wanted to visit this community that I wanted to do my research in, and I was told, please don't go right now. The political parties are heavily contesting in that area, and there might be violence, or you might get into trouble or get arrested. I have an Indian passport, so be aware. So I had to kind of wait for that kind of heat to die down. It was basically being heavily contested between kind of pro-government party and the Tamil National Alliance, which came out in the end as. But anyway, so the community I was visiting is in the south coast of Jaffna town, in the larger area, which is kind of inhabited by a fishing community known as, in caste terms, the Karayar caste. And this village, this rather what I'd call an underserved colony, is in a very urban space. It is located within this larger area of this Karaya caste village, community, which is called Guru Nahar. And my area is called Tirunahar, which means, if I understand correctly, which means sacred or respectful, which was given a name given by the LTT during their kind of de facto state in the north to remove any association of caste. And kind of a caste associated name before that was Titti, that was given to this place. The community traditionally belongs to a pariah caste, which is the lowest, in the lowest category of castes in Jaffna, which is the Panchamar caste, and has been in this community, has been in this location for 5 to 6 generations. The elder folk would say that, I mean, they were employed by the British under the British government as cleaners, and employed by the Jaffna Municipal Council as cleaners and sanitary workers for Jaffna town. There are also a couple of families living from different communities, but also belonging to the sub-Panchamar caste. One of these families are from Point Pedro, and another from one of the islands up north. These people originally came in from, I mean, they have family in Kandy and they have family in the islands in Narendivu, but have come down many generations ago. I'd also like to highlight that according to government records, the land that they live on is actually government land, and they have encroached on it and have been kept due to, have been allowed to be there due to political reasons and political parties having interest in those vote banks. I'll get to those implications later. So all of this was in the midst of a background of, it's been 5 years, the war has ended. Generally in donor terms, a good time to assess conditions of livelihood, a good time to assess conditions of well-being. The Sri Lankan state, as compared to other post-conflict states in the SLRC consortium, was relatively stable economically, politically, and therefore water and sanitation, which are services that I'm looking at specifically in this case, were relatively overall, I mean, nationally taken care of. I mean, in the sense the government says that it had met its MDG goals by 2012. A majority of returnees have gone back to their original place of residence. To keep in mind that a lot of these returns were forceful, there were many issues and allegations of kind of use of military force, sexual gender-based violence, and not kind of given options to return where they wanted to. But a lot of people have gone back to where they were originally from, which brings about this question of, okay, so who is excluded from these dynamics of post-conflict recovery, right? And this was kind of fed in from the fact, from literature coming in of this book called Caste Blind and Casteless, or Casteless, which is looking at, which is alleging that IDPs who mostly belong to lower castes were denied access to water, denied access to buying land due to their caste identity. And then this last part of emphasizing on developing urban centers, you see a lot of money going into town centers and a lot of money, built on this idea of comparative advantage, which the World Bank has published a paper on, where you have a basic sort of infrastructure, you put in money there, you make good roads, so you get people coming in every day from the villages, working there and going back. But this has implications for what caste and how caste intersects with class, especially in a very urban environment where lots of finance and lots of different kinds of jobs are coming up. Right. So the legacy of the war within the community had its own effects, which were, you had people who were obviously displaced in Jaffna in the late 90s, early 90s and late 90s, and they mostly were displaced within Jaffna itself. They stayed with church organizations because this is a Christian community, largely Catholic, with a few Protestants and a few other denominations such as like Assembly of God. And they lived, they were provided support by the church, or they lived with relatives, and they came back, kind of, the last families came back in the year 2000. So in a way, like we were talking about, I think Farzana brought about this idea of old IDPs and priorities being shifted according to these terms and labels. So in one sense, these were not considered the Vani IDPs with the priorities, and so they'd been resettled, so to speak, in 2000. Along with the legacy of war came a proliferation of NGO activity. So a lot of services of water and sanitation were taken up by NGOs, mostly funded by the church. And this is the Catholic Church. During the LTT kind of rule, within the community itself, there was, from men and women spoke about feeling that there was a sense of emancipation for their caste identity, and they felt that access to certain services, especially education, there was no chance in hell that a principal would deny someone on the basis of caste, because they would be in big trouble. Women felt much safer outside in public spaces and within the households. They said, husband, stop beating me. My husband stopped beating me, because if I were to complain, he would be in big trouble. And since post the LTT, people claim that, you know, these caste dynamics are resurging. People are kind of asserting their caste identity stronger, in a more kind of assertive way. This is not to say that caste kind of disappeared from the surface during the LTT time, though kind of it wasn't openly practiced as it was, but it existed within the household, definitely. So, coming to caste, it's a form of social and economic governance, kind of embedded in the Hindu religion, Hindu culture, and I've in my paper I've used the kind of description or a very broad definition by the International Dalit Solidarity Network, which in itself is a political stance that I'm taking, that I'm viewing caste as a discriminatory practice and not just as a social phenomena, that it is founded on basis of inequality and power relations. And so there's an explicit researcher bias that I've also tried to negotiate, which I had, you know, through my process, because I think by the end of it, there's also some sort of desensitization towards caste discrimination, that you kind of start seeing things, oh, but this is, you know, anyway, it's problematic at an ethical, moral level, on many levels. So I leave out this history of caste for now, and we can talk about it at any other time. But as for now, caste is extremely taboo, not only in Jaffna, but in the entire country. People don't want to be identified by their caste identity, especially in the public sphere. And it's kind of looked upon as backward, you know, talking about caste in a kind of open environment. And so, like, during my scoping visit, which I went, I think a month before I actually went to my field site, there were kind of two views. One kind of said that the LTT has gotten rid of caste. There's no more caste discrimination. LTT done an excellent job. Yes, they were very, very ruthless, but this is the effect. Another group of people, and it depends obviously who you talk to, said that caste has just, you know, it was swept under the carpet. It was always there. People are asserting themselves. So in kind of rituals and household, you know, when it comes to marriage and stuff, people are much more assertive about caste. And so because it was so sensitive, oh dear, okay.
Just halfway.
So I basically wanted to approach caste issues not explicitly, in the sense I never mentioned caste in my interviews. Because I felt that if I mentioned caste, things would be perceived through a caste lens. And these intersections is what I was interested in, and how you know, different parts of your identity, different parts of your lives intersect with caste. And so I never mentioned caste, and so my methodology kind of was partly conventional ethnography, partly kind of focused ethnography, where most of my time was spent on observing interactions of service exchange. So people at water access points, or going, or sanitation. So going to, you know, where do they go for their toilet? What are their toilets like? And I didn't get to spend too much time into kind of doing a very rich socio-cultural kind of study of the community itself. I was there for just under 3 months. Limitations we can come to. I mean, I wasn't living in the community. There were some ethical issues, but was kind of initially an observer but became a participant by the end of it, in the sense I think I was perceived as having certain allegiances, having a certain group of friends. You know, you hang out with those people, why don't you hang out with me? Kind of. So in some way I saw myself as a participant as well. Okay, so coming to my findings, what we have, I kind of had it in three. Oh dear, the mic is there. I need to be there. So, I think.
Go on, carry on.
So-
we'll work around it.
So this is the community of Tirunahar. I decided I've kind of made these into three kind of categories of location versus isolation, inside versus outside, and a vicious cycle. And these are reductionist in a way, in the sense they're all simple dichotomies. Boundaries are constantly merging, especially when I come to this part. The vicious cycle, I know it's a bit simplistic in the sense it kind of makes you feel that there's these causal relationships and one thing leads to the other, and it isn't so. But this is, again, very much a work in progress. At this point in time, for me, this is how I can articulate my study and my analysis. Anyway, so location versus isolation, urban town center, a lot of schools, public schools, Jaffna, the St. Mary's Church, a neighboring church, like just north of the community, lots of government offices close by. So a lot of footfall, a lot of people coming in, and a lot of people around. So when I used to walk from the bus station or take a bus or a tuk-tuk, I'd see a lot of people around. But about a week, 2 weeks in, I realized that, hey, I don't see people from outside at all, or people don't interact with people from outside. And one of the reasons, well, there are many reasons, but as far as this idea of isolation in the sense of spatial politics, as we discussed yesterday, of how spaces can be oppressive or marginalized communities. What you have here is a very high wall on both these sides, right? This is nearly 2 meters. We have a St. Patrick's College here, we have a cemetery here, and we have these lanes which all end in cul-de-sacs. And so what you have is no thoroughfare through the cul-de-sacs, and especially in the cul-de-sacs you have people who don't really leave that area. And this is especially for women and children and female, and girls and women who, tend to be, due to social norms, due to the way they're expected to be, would remain within these lanes over here and wouldn't really come out and meet people some people be passing through. And so you'd have households here who'd kind of interact and say hello to people, going across into the other section. But you would have people here not really coming out or interacting. And this was kind of, what do you call it? What's the word? Anyway, this was reinforced by the fact that how water access points were provided in this community. Okay, so the history of accessing water was that you go outside the community and collect water from public wells, and in those instances you had experiences of caste-based discrimination where, since you're from the lowest caste, you either take water last, or in some cases, if communities are very territorial about water access, then they'll serve you water. They'll give it to you. You can't access it yourself because of this idea of purity and water, which we can talk about. So basically, the kind of the problem or the problematic here was how public provisioning of water access kind of reinforces spaces. It keeps people within, especially women and girls, who are kind of have the prerogative of collecting water and using water in these spaces. So what you'd find is that instead of going out and collecting water and meeting up with other women would just meet their immediate neighbors, literally step out 2 feet and collect their water and go back and start cooking or cleaning, which would take place outside the house, but also inside the house. And so what you had was women and children mainly remaining within, very near their households, but the men would come out in the evenings to gamble, to play sport. Every day there was volleyball or football, which I played every day. I was pretty happy about that. And there was a big playground here. So the men you'd see men in these big groups, collectives, but women would be seen in, few numbers. And so there was this real sense of how the space and how public provisioning of these services really kind of limited movement, especially for women and children, and girls. Coming to the second aspect, insiders are basically people are interviewed within the community or observed within the community, and outsiders include government servants, kind of at a higher level, at the divisional secretary level, service providers, my key person interviews, neighboring communities, political activists, a whole range, journalists, and so interviews with insiders. Immediately there was a sense of we are a community that is discriminated against. However, I could kind of broadly divide this into three categories. Okay. And these were kind of one very small male population within the community that articulated caste very vocally and was very assertive about saying, caste is the main issue. So, and everything else, we can handle, but it's just this caste problem. And this was usually young males or middle-aged males that made this statement, very few in number. A larger groups kind of called for, articulated this fact that yes, caste is an issue, but in addition to caste, there are these certain norms and habits within the community that are reasons for why we are discriminated. There was this in their narrative, there was this causal relationship of, okay, these are the reasons we are not, these are the reasons we are discriminated against. And it was not specifically caste, it was caste, and it was articulated as caste and these norms. And the largest group kind of articulated, they never talked about caste. They only said, people smoke, people drink alcohol, we are all alcoholics, there are multiple partners, there's no marital stability, and these are the kind of reasons why people are discriminated against. So these were the kind of three broad areas that, can this be seen? Yeah. That people, within the community articulate this. From the outside, you had government servants, which kind of use these terms to describe the community. So you have alcoholics, thieves, uncivilized, all said in English, by the way, uneducated people, and very poor people. And here what I want to bring about the fact is that especially these uneducated people and very poor people were kind of signs of how caste is, how it strongly intersects with notions of class and of what I perceived as these structural issues of a lack of access to education, of historical marginalization and poverty. And the interviews with the outsiders also brought about these intersections, or highlighted these intersections with location and livelihood. Oh dear. Okay, with location and livelihood. And in this case, it was mainly about, okay, so if you belong to Tirunahar, then you are of this particular caste. And so the Karayar get much more respect than us, where Karayar is a very loaded term of area of location of your caste, name, your identity, and your livelihood, which is fishing. And so what you find is that you don't necessarily need to say that this is the caste. You have multiple associations with this term. Okay, so I will kind of rush through. I don't like to rush through, but sorry, go through these. Sorry. Okay, so the vicious cycle, if you remember, it's what this was after I talked to these outsiders, these government servants. again, I kind of had a very crude kind of hypothesis where I said that if government servants have these perceptions of the community, does this mean that, you know, services are affected, the quality of services are affected? And what you found is that people were, so in the case of access to sanitation, you found that people who did not have access to sanitation, toilets, they would defecate in the church, the cemetery, in the neighboring cemetery, or some women would they would defecate into plastic bags and chuck it over the wall into the playground. And so talking to the principal, he said, listen, if this kind of behavior goes on, how can you expect me to accept anyone from that community? And so this was a very clear kind of link of, okay, an access is being denied through multiple reasons, and you have, so access to toilets, being denied, and you have an access to education, or the quality of education being denied. So very, very, strong link with, between different services. Sorry, I'm going to take 3 more minutes of your time. Is that okay?
Yeah.
Okay. Lastly, I'd like to say how, with respect to gender and caste, where you had, when it came to access to water, you had women, within the community, water was drawn along caste lines. So if you belong to a different subcaste, you found this woman drawing water from a tap where these other subcastes drew water from. But women who did not have any access to water, in the sense couldn't pay the 60 rupees a month, would get water from neighboring communities of women from upper castes, from higher castes. And so there was this, I guess, this gendering in the sense where there was these networks between women that kind of overcame caste barriers, which was very interesting to see. And at the same time, there's a well that the community uses, and because the neighboring community perceives that this well is polluted because it is used by people of Tirunahar, it automatically becomes an exclusive access point for those people. So kind of how these things worked, both ways. So lastly, I'd just like to say that these kinds of, okay, coming back to this idea of these women throwing their, throwing these bags into the compound, and I would ask, okay, why does this happen? And you get these mixed responses about, oh, we don't know where to put it, or we don't like the principal, our children don't get admitted into school. Sometimes very directly said, sometimes very implicit. But what it did was it reinforced. It was like they were performing their caste role. It's ironic that it is their men who clean up the shit for the city. It is their men who come and clean up that stuff. And so there was this real angst, but it was reinforcing this role of caste. And to give another example, there was a man who was arrested from the community, and the community went on strike and said, we will not clean the city. And this man was given bail in 2 days and released. And for me, when I heard this, I was like, oh, okay, so these people are asserting their caste. They're asserting their identity, and there's an empowerment of sort. But at the same time, they're really performing that caste identity out. And so it's reinforcing in terms of outsiders' perceptions that, we will not clean the shit because we are the shit, we clean up the city. And so I found that these kind of this agency or this ability to protest was also reinforcing this identity of caste. Yes. To conclude, kind of since working at SEPA, which is looking to work in advocacy, working with politicians, with government actors, so how can we kind of recognize marginalized communities in the reconstruction phase? How can we prevent them falling back into status quo? Challenges with research uptake. How do we talk about these issues in the public, with politicians, with the government? And lastly, how useful are perceptions? And Suman's, your data was collected on the basis of perceptions. And I think what we have to realize is that perceptions are not just statements set out of the blue. they're very strongly embedded in history and culture, and there needs to be a real deep analysis of what these perceptions mean and what these perception surveys imply. Thank you very much, and sorry for taking too much time. Yeah.
Thank you. I think you had a little credit left over from Suman, so it's absolutely fine. So thank you to all three panelists. Ramya, if you wouldn't mind joining us up here for really quite fascinating presentations. I think we've had a panel of sort of, perhaps could be described as contradictory trends and sort of contrasts between Nepal and Sri Lanka. You know, on the one hand, you've got Suman talking about increasing access to, increasing free to access healthcare in Nepal and some of the complications of that process. And then on the other hand, you've got Ramya talking about the very successful and very well-known example of Sri Lankan free to access healthcare and the consequences that it has had for Sri Lanka's performance and human development indicators and so on. But yet a sort of a rolling back of this potential, or at least the potential for the rolling back of this through health sector sort of policies that are not being widely discussed, and some tensions that might exist there. And then you've got, again, a nice interesting contrast between the sort of the transformation of caste exclusion in Nepal with sort of discrimination no longer being somehow miraculously almost wiped out. And I think I'm quite interested to hear about that because, you know, how does policy level or legal leadership translate into the transformation of community relations that are embedded in everyday practices and in sort of sort of embodied subjectivities of people both of different castes. And then you've got Aftab's work, which for Sri Lanka is really important, given that there is this complete silence, or there's a huge gap just in the sort of academic literature, but then certainly in the development literature, caste just doesn't come up, sort of as largely as a function of the fact that it's been erased from the public discourse within the spheres of, you know, government, non-governmental action, and so on. And so it would be quite interesting to also look at what that might have meant in terms of, I think in your paper, you didn't bring this out here, but you talked about the fact that some of those access points and some of the toilets were actually built by development agencies.
Mm.
Like, and, you know, it might be interesting to look at whether those, and if you could speak to whether those engage with the issue of caste, or whether they were using other categories of vulnerability like, you know, gender, women-led households, and so on, and whether that meant, you know, this uneven distribution of services within the community is related to that. So before I open up, I'd like to just make just a couple of quick comments that might help frame the discussion. One is that it seems to me that, you know, it might be helpful for us to refer to the framework around access. So we're talking about access that is widely used by WHO and so on, which has its basis in international law in terms of the economic and social rights committees, sort of general comment 14 around, which defines access as availability, accessibility, both in terms of non-discrimination, affordability, physical access and information availability, acceptability to the recipients, and of course quality. And I think, you know, Suman's talk really kind of could quite easily be sort of discussed in those terms. But I think the other two talks as well, perhaps. So that's one thing. The other comment I just wanted to make is that is sort of to situate Ramya's paper in the sort of in terms of where it fits into post-conflict policy, and because a lot of what she talks about, I mean, the policy initiatives both of the UNP government as well as that preceded the Mahima Chintana, as well as the World Bank reports, come out of a particular moment in Sri Lankan political history, which is the 2002 peace process, when a lot of donors actually approached that very tentative and ultimately unsuccessful peace process through the framework of post-conflict reconstruction and transformation. They sort of jumped the gun a bit. But it might be interesting to think about, to look at that in terms of how do these frameworks and analyses of development actors and major donors kind of get incorporated into state policy, and then why is it taken up, and so on. So with that, I'd like to open the floor to questions or comments. If you just indicate who you are, but also to whom you're directing your questions, that would be great. Thank you.
Okay, good morning. So my name is Cherie Bennett, and I'm with the International Rescue Committee. Thank you all for your presentations. I have two questions. Two sets of questions, I guess. One set for Suman, one for Aftab. So, Suman, you mentioned the sample that you used for your perception survey. I was wondering if you could give us a bit more description of that sample, how you selected them, and a bit more of the characteristics of the people that you spoke to, because of course I think that's extremely important for how we interpret the information. And I also wanted to know, again, just for descriptive purposes, a little bit more about the distribution of private services. So you said that where public health posts were present, the services were not necessarily available, right, or medications or so on. So the alternative was to seek assistance from private health centers. So in my mind, I'm just wondering, like, mathematically, what does this look like for people? Aftab, so I think it's really, really fascinating thinking about the intersection of caste and class and this sort of return IDP identity. And if we all sort of think about individuals as having these identity repertoires and identities as kind of fluid, some more than others, and having to think about access when we have insiders and outsiders, but those definitions actually change depending on who's around and who you're talking to, right? I wasn't quite clear from your presentation, is there some sort of clear line of demarcation? You told me who you were referring to as outsiders, but who do people there consider outsiders, you know?
Okay.
And then the other thing, thinking about both of your presentations, you're speaking about ROLPA in a relatively rural area, if I remember correctly, and you're talking about an urban phenomenon. So I was wondering if you could reflect a little bit more on that particular aspect. What makes your work stand out or different because it's focused on an urban setting with all these intersections of identities? Is there anything extremely, extremely different because it is this urban setting?
Thanks. We've got one more question. Just to the back. Yeah. You have a question?
Hi, I'm David. I'm an academic tourist. I hope I don't have to become a medical tourist. But the time is coming. But South Africa has a lot of medical tourism too. Yeah, I come from South Africa. So Ramya, I've got questions for everybody. I hope I don't take too long. Yeah, in the BRIC countries, Brazil, South Africa, people are really talking seriously about pushing forward with public health, reversing that huge gap between private and public. The public's for the poor, the private's for the rich. Why is Sri Lanka going the other way? And is this within a global context? Are certain categories of so-called third world countries going more private? And are there different policies, like if we're talking about the North, are there different, what's the relationship between provinces and the central state as far as health policy goes? And do these characteristics remain the same in different parts of the country, or is this just all in Colombo, where the rich and the people with good salaries can get these health services? And the incentives for doctors, I mean, when did this start? When did this, doctors can work both in public and in private, and how much of their time is regulated in one or the other? What are some of the rules there? Anyway, just sort of. And in Nepal, why did the Maoists attack public services? It often happens a lot in public protests in South African cities, is that the demonstrators will burn down a library or burn down a school, something like this, because they are representations of the state. But they're also services, so there's a sort of a contradiction there. But secondly, where do the resources come from for public health? Are they coming from various bilaterals or multilaterals? And what's the relationship between the state and the international donors, and what's being done to get this on a better keel? And thirdly, with the North and the reinvention of caste, I'm kind of an old-fashioned Marxist, and the older you get, you start just looking at the bourgeoisie. You want the rich. You want to look at the rich. How are the upper castes reinventing themselves? What state structures, what NGO structures, what tasks are they taking so they can allocate resources, and perhaps that gets mediated, in a new way by caste, whether they're in the private sector or the public sector. So is that reinvention coming along there too? And you mentioned the Roman Catholic Church. How does that articulate, if it's a donor, a big donor? And I guess that's about it.
I had a couple of questions for Aftab. I was a little confused about the methods, so I just wanted some clarification. You said that you asked them some questions about how are we discriminate. Did I get it right? You asked them how they were being discriminated against? No, you didn't. Okay. No. I thought because you were saying that those statements were in response to some question that you had.
Oh, well, they were not in response to a question, they were part of conversations. So in the sense, what I was just talking to them about was, these were conversations where there were kind of some semi-structured interviews where I was talking about, kind of life histories or, okay. What their daily lives and stuff. And yeah, so these would just come out in like, oh, I had a problem, today about something.
Okay, so my question is this. When you talk about that, when you're talking like that, who did they identify as we? I was wondering who is the we in that? And did that we change depending on who you spoke to? For example, if it was women, was the we different? That was my main issue there. Okay. And secondly, could you just elaborate just a bit on the 60 rupees a month? I was interested in that. You said there was 60 rupees for water. Thank you.
We'll just let them respond and we'll take next round. Thanks. So who would like to go first? Someone?
Thank you for the question. About the sampling, what we did is that we tried to make the equal sample of men and women. And for Dalit and Janjati, what we did, when we were doing our study in the Liwang area, 3 wards were selected very nearby health post. And what I did, we compared the composition of population, what is the composition of population and of different caste groups within that territory. And what we found, Dalit were in small numbers, and Janjati were a little bit high, and Brahmin and Kshetri were a little bit majority. That's why my sample is also, Brahmin and Kshetri has the 25 samples, and Dalit 9 and Janjati were 18s. In that way the sampling was done. And most of the time what happens, Dalits, most of the Dalits and the poor who were not able to afford the private sector, they were taken as the marginalized and poor people. They may be from the Dalits as well as from the Brahmin and Kshatriya community also. And about the private sector, in Nepal, we have a 3 strategy of government: preventive, promotive and curative. But when you go to the private sector, they do not try to invest on the preventive and promotive. They just try to do business on the curative perspective. They exactly saying they do want to have a business on the health services. And in Rolpa, you know, very rural area, and people are very poor. They cannot afford the private sectors in the rural area. And even the private sector could not like to go to there to make the investment because there is no profit. That's why the only one sector who can provide the services is the government. And sometimes you can see some people who just do some kind of health practice, and they just open the shop and they just try to they just say the check, they just to build up a shop and set the board health medicine shop. And some often what happens, those people are uneducated and do not get the services from the government health post, they go to that private clinic, but that private clinics are not registered and they are not well equipped also, and they are doing the tricky business to gather the money from the very poor people also. And that's the also very big problem in the rural part of Nepal. I have a case study of Budagaon. It is very rural part of Rolpa. What happens, a woman was very sick and she went to the health post. And what happens, health post assistant said he could not cure her, and he just referred him to the district hospital. But what happens, she really do not have the money to go to the district hospital, because for the Rolpa you need around 5,000 or 6,000 to go to the district hospital, because you cannot go alone, and you need to have somebody to take to the district hospital, and you need the transportation cost, accommodation cost, and different costs associated. That's why she went to the private clinic, and the private so-called doctor said that he will cure her disease. And what happens, the shopkeeper just gave the medicine haphazardly, and laterally she died because of some medical problem, you know. And what happens, and the husband of the died woman came to the private clinic, but the private clinic just gave 5,000 rupees and he ran away from that area, you know. And there was no any legal procedure and no any kind of things. And later on, when we went to the field, the man was saying that state murdered my wife because there is no facility of health system. That's why my wife got killed by the unskilled medical technician. That's the case, you know.
And just in terms of the numbers, I wish I asked about, you know, how some of these sort of fly-by-night medical providers, how many are there in the area you described compared to the number of health posts?
You know, the health post, according to our health government strategy, for one constituency area there is one health post, and for one BDC there is sub-health post. But you know, there is only the effective program of health post is the vaccination program, which is is making an effect in the rural area because of the decrement in the infant mortality rate and other kind of things. But you know, when you see the private clinics, and you just who pass the 10th class and have some knowledge of medicine, he started to open, because he know the scope of the medical shop over there, and they are doing the business, just business.
There could be any number of them. There's no range.
No, in Liwang area there were little bit more than the Budagaon. Budagaon is very rural, and there were just 2 or 3, but in Liwang area, the headquarter of the district Rolpa, there was 10 or 15 private shops. But you know, the health workers who are employed in the government health post, he has owned the private clinic, you know. And what is the problem? You know, the people are blaming that the medicine which is always lack in the health post are going back to the private clinic, you know, and there is no any monitoring body, nobody. And you know that lots of illegal and non-registered private clinics are being operated in that area because of the political influence of the people.
I think it's a good point, which we switch over to Rami. And perhaps Rami, when you're talking about some of these, clearly there's an issue of conflicts of interest between people who are invested, both as service providers in both sectors, but then also potentially those who are invested as policymakers and so on. Also, operating in both sectors. So perhaps if you could speak to that a little bit in Sri Lanka in terms of, it's a tricky subject, but in terms of involvement of state officials and so on in public or private healthcare.
I'm actually not sure I can address that, but I'll try. Is this okay? First to address David's questions. I think Brazil is quite an exception in that they have publicly financed a health system, and but I think there's also a private system that is actually qualitatively supposed to be much better, and this public system is weakening, and they have those problems. And I'm aware of South Africa having in 1996 there was this huge change in universal access, but if
that they are planning a national health system, maybe 10 years from now, which is big.
right. Yeah, so if you take Russia, India, China, they actually do have health systems that are encouraging public financing of the private sector. So with these different, the global economic environment, there's a shift towards that. And so I think what's happening in Sri Lanka actually can be put in that context, because what they are trying to do is basically what the WHO Macroeconomic Commission on Health in 2001, like they're sort of in cahoots with the World Bank. They are actually now promoting this concept called universal healthcare, which is the public financing of the private sector to expand services. So what we might see in Sri Lanka is the expansion of the private health sector, and then eventually the government contracting out to the private sector, which is happening in those countries. So when I said Sri Lanka is sort of different, I meant in terms of socialized medicine. That system doesn't really exist. And in terms of central and provincial ministries, the health services was devolved in 1987 to the provinces, but financial devolution didn't really happen because they are very dependent on the center, but it all comes under a centralized system. So I mean, in Jaffna, which is where he's talking about, it's in the northern province, so it's would be coordinated through the Northern Provincial Director of Health Services office. But it's the same system, the public system. I can't speak to the private system because it's really not an organized system. They're just independent institutions here and there providing services. And yes, there's a concentration of private healthcare in the Western province, definitely in a big way, especially advanced technologies and biomedical equipment. But then in rural areas, people go to see doctors who are actually having their little practice while working in the public hospital, also having their own GP practice, and actually encouraging people to come to that. So that is also accounts for a lot of outpatient contacts. And incentives for doctors to work in the private sector, there's no regulation at all, actually. So they're working in both sectors simultaneously, and there are all kinds of conflicts of interest. About private sector policymakers being involved in, sort of involved in policy, I think that in 2006, with this act that was passed to regulate private healthcare, there was like a majority representation of the private sector, which is kind of the problem. But as far as I know, I think it happens more along like World Bank, Ministry of Health coming together, and this other thing is happening. But I don't really know too much to comment on that.
Perhaps that's an area for further study. I mean, certainly, I live in a relatively rural district where it's very clear that the people on the board of the private service provider also have past and current representation in decision making within the state sector, and so would be consulted, for example, in that body potentially. So that's something that is worth sort of, I guess, illuminating as a potential driver or shaper of some of these processes. After that, I think you have a fair collection of questions. I'm just trying to get a sense of where we are in time. We've got about 18 minutes, so
Yeah.
I'd like to take another
Round.
so yeah.
Okay, thank you. Thank you for your questions. This insiders versus outsiders, who are these outsiders, right? And so I think there are two ways to look at it. So there's a very clear physical demarcation when it comes to the area you occupy, especially for outsiders. So outsiders are very aware that I cross this road and I'm in this particular territory. And so there's a very, very clear distinction, not only in that area, throughout Jaffna. So you are identified, like your caste is identified according to where you live or where your parents live. So, and literally, oh, do you live on that side of this road or do you live on that side of this road? At the same time, for people within the community, this whole notion of being an insider and outsider changes, is very fluid. So, for example, someone belonging to that particular caste in that community, when he goes and works at the JMC, say as a clerk or as a peon or as a security guard, there is, I mean, what I perceived was there's a shedding of that particular caste identity, where you are in a white collar, relatively like a white collar job, and so you're interacting with all kinds of people. You have a certain amount of authority in a bureaucratic setting. The label of a government officer, being a government servant, is very sought after in Sri Lanka. So these are all government servants, and so that identity shifts. And then when they come back into the community, the outside is a very negative space. But when they inhabit it in a way like so, but for in the same sense, people who work in cleaning sewages, for them they experience caste-based discrimination in their work. So they're going out and they're cleaning up, and then someone will say something or someone will make a reference, and for them alcohol was the way out. They're saying, we do this kind of work, we face discrimination almost on a daily basis. And so I said, would people call out, like, say, an abusive term? He said, no, it's not. No one dare say that to us now, but it's there. So in their perception, they're always being discriminated against. So yes, so in a physical sense, very clear demarcation. But for people inside, I would really say it's very fluid in that sense. But again, so this peon or this clerk who goes and works in the JMC during the day and is interacting with these people, and what I called shedding that caste identity, still very much belongs to that caste, because so the JMC employs people specifically from that community. Yes, they have an open merit-based application, but kind of preference is given to people whose parents have worked in the JMC, which is, if you belong to this caste, you have a right. And so what that's doing is that this access to an employment, to a government job, which you have lower interest rates on your loans, you get a better dowry. For men, this is people are not migrating, people are not leaving. People stay. They say, we have this job assured in this time of so much uncertainty. You don't want to get onto a boat and try to go to Australia or wherever. And this is something that's pretty, it's a decent deal. So yeah, that was that. The urban aspect, very good question, because this is kind of the first. This is like first field study. I want to compare it with a rural area in Jaffna, which would obviously answer many of those questions, as well as an urban area inhabited by the same caste of people, but who have kind of risen out of this this kind of label. So in the sense who've got access to education, good schools, have become, got into white collar jobs. And so that comparison needs to be made. But there's this idea that an urban setting, that the market, that free market, that opportunities would kind of, diminish this caste identity, in the sense that, if you have that white collar job, so a lot of people in the government servant might belong to a lower caste, but because they have access to that job, or they work in a private company and they belong to a particular class now, that association is not made. But I guess what I would argue is that urban spaces reinforce caste as well. Especially in the case of Tirunahar. Yeah? Did you want to make an interjection? Okay. Is that?
There's more to be discussed.
Yeah. Yeah.
One question that I think wasn't picked up that might be useful was one directed to Suman, actually, David, which was about the international donor role in the Nepal context and these changes. One in terms of financing, and perhaps then in terms of the policy decisions and support for that. How did the international donors in the post ceasefire context?
In case of international donor, there has not been so much investment on the Rulpa district of Nepal. They have a channel that they can give the amount to the government, and the money comes from the government to the district level and district to the BDC level. But there is no any clear and direct investment of donor on the health system of the Rolpa district in Nepal. That's the thing. And you also ask about the Maoist attack to the public services. Maoist during the insurgency, they make a strategy that they do not like to have any kind of government representation in their own area. They try to just run their own parallel government, and they just used to say that the representation of central government or the Kathmandu government is just useless, because they are not providing any services. They are just doing their job, and they are just act like a spy and the unwanted people of that area. So they just attack the different public services, and they also try to create a gap between the people and the state. If you broke the bridge between the people and the state, that makes they can motivate people on their own way, because always the service provided by the state is the bridge between the people and the state. That also legitimizes the role of state in practical, but they just try to broke the bridge and try to manipulate the people, just further strengthening that state is really unaware about the people, and state do not care about the rural people. See, they again manipulate in that way, and they just try to make the people against and very aggressive against the state. That's how they mobilize the people against the state. They did, and I think they were successful on that time. Rolpa was become a synonym of Maoist conflict, and even a police person were used to provide some protection money to the Maoists on that area, but that was very informal. That was a kind of very heavy influence at that time.
And the upper caste reinvented themselves?
Yeah, upper caste reinventing themselves, I don't know. And that's primarily because my sample, where I was, people I was interacting with did not belong to that caste. But the idea I get is that there's this recognition that the upper caste is now a minority community. And I don't know how that's translating into, what they're doing as a group. But there's this definite idea that, reality that there are less of us now. A lot of them have left abroad, gone abroad, belong to the diaspora now. Going to the we question I shall address. Okay. The Roman Catholic Church. Well, there's a very strong historical link there in the sense of the history of proselytization. And so in the paper, what I argue is that the link, the kind of network of donors that are linked to, so Caritas, that is linked to the church, gets funding from the church. Again, kind of, I would argue, reinforces that caste identity, that, okay, we have to take care of these people. People appropriate that identity, asking for services. And the church is, in services at least, it is very much part of, it holds a certain amount of power, in the sense they have the power to distribute kind of school principals in different schools. So a lot of the principals belong to the kind of upper echelons of the church. They're all priests, all Catholic, and so so the Roman Catholic Church definitely plays a very, very significant role in accessing services, as well as kind of as part of of the culture of that area. Who is the we? The we is, well, for men and for women, again, very, very loaded. You're right. Oh dear. Okay. So the community that in Tirunahar is mostly, they're all intermarried, so they're all relatives, and the few families that are from elsewhere are not part of that particular system or that support network necessarily. But so and then so this is one of those, it's so layered. So if a woman is saying we, as compared to a single woman is saying we, and I frankly don't know what that we implies when it's a woman-headed household and when it's a household where there is a man and a woman. But there's a definite, I can definitely say that we in most cases refer to us people, this family, our caste, and I would argue that the we was always was mostly in reference to we are like this, we are like that, we don't get this, we get this, we are able to mobilize, and it's a reference to their identity as more as a community than individuals, I would say. There was, and very rarely did people say I in that sense. It was always a we. And I know that's not a nuanced enough kind of answer, but that's what I have. The 60 rupees a month, elaborate in the sense, so this is the cost for each family accessing water taps provided by the government. And it's around 7 to 10 families at a tap. And so one person would come collect this money, go to the JMC and deposit it. Some people didn't pay and still kept accessing water. For some people who couldn't afford it or decided not to spend that money on that, on the service, would ask neighbors, as women-headed households did from neighboring communities, and got their water. Yeah.
Thank you. We have about 5 minutes, let's say. So Zainab was, and then
I have a question for Ramya. It ties into this idea that's been coming up of medical practitioners being divided, their time being divided across the public and private healthcare. I was actually curious as to whether your analysis looked at this particular issue of medical skills being shared across public and private healthcare systems, and how that feeds into a post-conflict analysis of needs and availability of services and so on. And I was just wondering whether your analysis looked at that as aspect.
Especially in the context of the public sector trains at no cost are public.
Yes.
Healthcare professionals and things, though there are exceptions.
Yeah.
Yeah, I guess given also the lack of time, just more kind of comments, and I have more questions later, maybe individually. But like this, from Ramya's presentation, also trying to tie it to yesterday's presentation on education, for example, right? I mean, education and health being so important in Sri Lanka, given our long history of free education and health. Why, at what point, on the one hand, Ramya was saying that, there's clearly a shift, but in the documents, it's all very vague, right? Are they doing this? Are they not? And so just from looking at the documents, it's very hard to pin down, and they don't want you to pin down also. That's the kind of form of governance of this kind of privatization. And also, I think in some ways, health and education, all of us remember those huge prison uprisings in the last 2 years, right? In Velikada, when there was, because of prison conditions. I mean, people are stuck in this space, and there's going to be a burst, right? Huh? No, they are not. But they want to move them out of the city so that people can't see those kinds of uprisings. Or when the fishermen's struggle just erupted, right? Because it's about their work, their labor, their production, and when they increase it. But in education or health, it's like slow death, right? It just starts to deteriorate slowly, and then, well, one patient may not get the proper access, the next person less, and it's kind of, so what is the kind of glue that brings it together? And that's why I thought, for example, in the case of education, it was the Futa struggle and the kind of 6% demand that said, no, we have a crisis of education, but what is the kind of glue that can bring the health sector in that kind of thing? And one thing to Aftab, this is a huge issue, right, in the north in terms of caste, but I think it's really hard I think we need to spend a lot more time kind of engaging with it, because I think the dynamics are so different, right? I see it more as a process in the north now of social exclusion, right? And what I mean by that, it's not like caste in India where there are all these like atrocities, right? People getting, villages getting massacred, people getting hacked. It's not that kind of violence that's there in the post-war context, right? It's much more subtle of pushing people to the side. And when there's that kind of social exclusion, I'm not sure the language of discrimination works, right? I mean, we go with this idea of discrimination, which we have kind of in social science, we've arrived. I'm not sure I'm not even sure how I would translate discrimination into Tamil in a way that it's in the kind of local, like vernacular, right? I mean, people talk about oppression, which has been there from the 60s, they remember, but discrimination is something new, and services. But when there's social exclusion, necessarily you don't even get to the point of discrimination, right? You know what I'm getting at? So you're thrown into an area where you're not in touch with either the state or capital to be discriminated, and how to think about this new process. And again, things are in flux, things are going to change, but I think the kind of questions we ask, the kind of conceptual vocabulary we deal with is also it's very new terrain, and there needs to be a lot of thinking.
Thank you for that. I think it's very interesting. And the point you made last about before you get to formal equality, this underlying structure of things actually impede you have to get to that point where you can encounter it. I was thinking just a quick point about the nexus. Eric Meyer, I think, wrote about the fact that the Sri Lanka state became the primary provider of health, education, and jobs. And you see that those are the three areas where you have this sort of really complicated process of, let's say, disintegration, undermining of it, and so on, but where it's very difficult for any political actor, given that in a sense, this is the role of the state in the late colonial period, in the transition into independence, so that some of these services predate electoral politics, and electoral politics, in a sense, has come in on the back of those, and that's in part of the access to those three services have been a key part of the sort of patronage that political parties and their representatives have managed to have traded for votes. So, I mean, if you look at healthcare, I think Ravi Rananelli talks about it. I don't know if he's written about it, he's spoken about it publicly, that we don't have rational allocation of health facilities. We have our hospitals were built on the back of political patronage systems, right? But we've had positive outcomes as a result. We've got much better cost per unit figures.
One quick thing is also that it came out after Dortmund, right? So it also came out after universal suffrage. So I think we focus on the patronage part, but there's also a democracy element to this that I think we need to reclaim, right? We shouldn't give in too much into the discourse of patronage. Also, in 1931, there was universal suffrage in Sri Lanka, which...
There's a question here about the nature of the state, I think, and the way in which the state and state actors within, the state is just the way in which actors within the state who determine what the state policies and state actions entail, how their thinking and their interests have shifted over time. But then also, I think we're neglecting to really look in detail at how citizens, subjects, however you want to frame them, in Sri Lanka, also perhaps sign their relationship to their articulation of what might constitute the social contract as personified by those three key dimensions of reciprocity between the citizen and state, are also being transformed, perhaps through experiences of services, perhaps through exclusions, and so on. And that dimension I see very little being done on right now, and that might be quite interesting. Yeah. But I think
Can I just quickly...
Can I make a comment because it's related to what Ahilan said?
if you all don't mind going over by a couple more minutes, I think it's very interesting. Yeah. So please go ahead.
I just wanted to say about the vagueness in education as well. There's a vagueness, and when we were trying to figure out what the policy changes were, it was clearly hidden. You couldn't ask anybody. So they are making decisions, and it's very, very well hidden, and it's compartmentalized. But what is interesting is that there is obviously a bigger plan, because what's happening in education and what's happening in medicine is just so consistent. And also when you look at policies, especially policies and programs where the World Bank has been involved in, you see sort of these different projects coming in waves. But the same sort of these particular things that Ramya was talking about, you see them consistently coming in and attached in different ways. But that plan is there throughout, over a decade now. You see this across different projects.
Thank you. I'll let the panel respond.
Yeah, so I want to just also first to Zarina's question about private and public sectors, and the public sector kind of providing employees for the private sector. Now that's all that's happening in a way that both sectors are being kind of supported in rural areas and in provinces outside the Western province. But actually now you see that with these big hospitals like the Central Hospital and things like that coming up, there are, at least I've been reading about and come across this in my work also, that people are actually fed up with the public health sector and opting to work in this private sector, because there's like a fundamental change in how we are perceiving private healthcare as these huge hospitals that are now better than, I'm not talking about everywhere, just one or two maybe, have better facilities. So there are specialists there's a dearth of specialists in rural areas, and they're actually choosing to work in the private health sector. But then that situation is slightly different in rural areas for the reason that I said. But I don't know how to connect that. I haven't thought about how to connect that to post-conflict, so I'm not going to try to address that. In terms of the vagueness again, so something that, I was rushing through that last part of my presentation. Actually, it's not just vague. There are a lot of things that have happened that are consistent with those policies. So, for example, security, laundry has been contracted out already, and at NHSL in 2008, they started building paying wards, and now they have paying wards. At NHSL is the National Hospital of Sri Lanka, the biggest hospital in Colombo. So it's not like this is just, and as Ahilan, you told me, they're like doing this pilot project in the northern province on like doing this cluster GP system, which again I think is based, I'm not sure about this, but it sounds like it's based on the NHS, the recent changes that happened with the NHS, where they're again making GPs purchase. So it's about separating providing and purchasing functions in health systems to make them more competitive and efficient. So I don't think it's at all vague, actually. I am sorry I didn't address that part in my presentation because I was running out of time. Yeah, and about glue, what was that? You said something about glue. I'll talk to you later about that.
I think on that note, I would like to thank everyone for a rather engaging session. So thanks very much, and please have lunch together.